So thank you everybody for attending this session. It's leveraging NIH network trial for your ancillary study proposal. I'm Peter Ho, I'm the moderator, and we have a really great presenter here. Jane Han, and also Jonathan Elmer and Joseph Miller here as listed. And will give us different parts of how to propose ancillary studies or writing aims and benefit and others. So I'm gonna have and get it started. In terms of first speaker will be Jin.
There we go. So I can't see people. I feel like I've gotten shorter as the conference has gone. I'm like, I can't see over, and I don't know, maybe it's, maybe I could use this. What? Podium, yes, yeah. This podium is like huge. Okay, just switch on the mic. Can you hear me now? Yeah. All right. So today we're going to talk about ancillary studies, and I've started my career, my R01 career and my R career with ancillary studies, and it's really helped me and answer some important clinical questions that would have been difficult if I started alone. So what I'm going to do is I'm going to be talking about what an ancillary study is, and then talk about the benefits and challenges. So before I move on, I have to talk about disclosures. I received funding from the NIH, PCORI, CDC, as well as from Merck and Geriatric Research Education Clinical Center, which is part of the VA, but I have no conflicts relevant to this presentation. So what is an ancillary study? So in the strictest term, an ancillary study is a study that collects additional data and new data from patients for an objective that is distinct from the parent study. So, and usually these ancillary studies require separate funding. And one thing, I'll mention that I'll say usually because there's always exceptions to the rules. So there's several types of ancillary studies. So you have ancillary studies that collect additional prospective data during the ED or hospitalization course. You also have additional prospective data that can be collected after they leave the hospital, follow-up data. And also additional analysis of existing data, such as biospecimens, can be an ancillary study, as well as collecting retrospective administrative data, such as a CMS database, and that could be an ancillary study as well. So these are some examples of some ancillary studies, and if you guys, if I make a mistake, please feel free to correct me. And one thing you'll notice that a lot of these ancillary studies have really cool names. So everybody here knows the SAR network. So for example, the SAR network is doing the ICECAP trial, which is looking at the optimal duration of therapeutic cooling in patients who are survivors of cardiac arrest and are comatose. And Jonathan here successfully got funding to do an ancillary study. His ancillary study is called PreciseCAP. And this is an example of a study that's collecting prospective data during hospitalization. And he's actually doing, collecting a lot of neurological biomarkers, so EEG data, as well as brain MRIs, head CT, and also looking at medications like sedation and analgesia, and all in the effort to predict the optimal duration of therapeutic hypothermia using machine learning. So really cool stuff. And hopefully identify patients, for each patient, it's like precision medicine, look at like what the optimal duration on the patient level is to maximize functional outcomes. This is an example of a study where we added follow-up data to an ongoing randomized trial. So the parent study was called the Violet trial, which is a pedal network sponsored trial. And this trial compared vitamin D versus placebo and only looked at short-term mortality. So what we did was we applied for funding and got funded through the NHLBI R56 mechanism, where we added 12-month cognition assessments. And this is just another example of a follow-up study where we added follow-up and secured funding from the NIA. So the parent study was called the ORCID study, where we compared hydroxychloroquine versus placebo, and we added a 12-month neuropsychological assessment. And notice that the funding doesn't necessarily have to be from the same institute. So this was funded by the NHLBI, the parent study, but I got funding from the NIA to do this ancillary study. So these are examples of how an ancillary study can use existing data, leverage existing data. So many of you guys know in this room what the process trial was. The process trial compared catheter-based early goal-directed therapy versus protocolized care versus usual care in septic patients in terms of resuscitation. And what Peter did was he actually leveraged the biospecimens collected and got an NHLBI R01 to measure biomarkers of endothelial permeability and hemostasis, and looking to find if there are any biomarker profiles in which patients responded better in specific arms, and also wanted to see if these biomarkers better predicted 60-day mortality. And lastly is an ancillary study by Joe Miller, and notice I'm highlighting my colleague's work here. So, but Joe actually is using existing data of the BOOST-3 study. The BOOST-3 study is another SIREN trial, and the BOOST parent study is looking at how, I guess, treatment based on intracranial pressures plus tissue oxygenation versus ICP alone, how that affects outcomes, so treatment guided by these two strategies. And the nice thing about BOOST-3 is that they're already collecting a host of brain EEG monitoring and the cardiodynamic data. And I don't know how you guys did it, but he managed to get an R01 from the NINDS to use existing data so they can phenotype autonomic dysfunction using this data. So apparently it's computationally extensive. So he's able to justify this to the NINDS. And he's going to see if this predicts multi-organ dysfunction. So what are the benefits of an ancillary study? So it's more cost-effective and efficient than a standalone study. So screening has essentially been done, and you can use data that's already been collected by the parent study. And if the parent study is a randomized trial, the randomization and treatment administration have already been done. And that's huge because those are very expensive propositions. So an ancillary study is also not considered a clinical trial, and as a result, you don't need a DSMB. So all this leads to lower costs to do an ancillary study. But there's several challenges of an ancillary study. So first is that it can increase patient burden and may impact recruitment and retention of the parent trial. So I know that this is something that Jonathan really had to think about when he's adding all these measurements during the hospitalization, and what you don't want is having these patients drop out from the parent as well as the ancillary study. And also, a lot of this stuff may be labor intensive. So for example, I had to get my patients come back to the local sites, get informed consent, and with the video conferencing neuropsychological testing for Violet Bud. So you need buy-in from these sites to actually do these activities. And the other thing is the baseline that data collected for the ancillary study may be missing or less than ideal. You got to make compromises. A lot of times, what you want. So if you did a standalone study, you can design the study and have the optimal baseline data collected, but oftentimes you may have to compromise what's collected in order to avoid overburdening the patient. So other challenges is that ancillary studies are usually performed in a subset of sites. So I think, Jonathan, how many SIREN sites are there? 12. 50 enrolling, and he's only doing it in 12 sites. So there are 30 plus sites for Violet and only enrolled in 6. And ancillary study enrollment often begins in the middle of the parent study data collection. And the biggest thing is that parent studies may stop early, right? And you're kind of screwed in terms of sample size. So that's what happened to both my studies. The studies were stopped early due to futility. So as a result, you end up having fewer patients and lower power. And lastly, is additional challenges for if your study's adding follow-up assessments after hospital discharge. Oftentimes, the contact information is suboptimal and patients die, so you lose those patients. And patients often don't know about the follow-up study, so when you call them, it's like, who are you? So as you know, I get robocalls all the time, and I don't answer my phone, and I'm not going to answer a phone who's trying to call me up if I don't know about the study. And getting consent over the phone is over-challenging and after hospital discharge, and this leads to higher loss of follow-up and refusal rates. And oftentimes, there's a difference in attrition that can lead to confounding, and that's one of the challenges for ancillary studying. So other considerations is that you really need to plan carefully and communicate a lot and coordinate a lot with the parent study team. And before we embark on these ancillary studies, there's a lot of conversations that occur, a lot of back and forth. And a lot of decisions that need to be made. Is the study team going to be integrated into the parent study team, or are they going to be separate? IRB-wise, are they going to be integrated into the parent study IRB protocol, or is it going to stand alone? And funding-wise, what are the natural funding sources? And they're going to be touching on that in the subsequent talks. So in conclusion, ancillary studies is where you collect new data from a parent study, for the most part, for a new objective. They're cost-effective and efficient, but challenges do exist. But I think the benefits outweigh the risks, and I think the institutes also see that as well. But it requires careful coordination with the parent study investigators to make it happen. Thank you. Or we can have a discussion.
We'll have that out there. Okay, then we'll have the next speaker. Thank you.
You probably know better than where it is.
Is that yours?
Ah, this is Jonathan. Your name.
Oh, you?
John.
Yeah.
Or you can phone. It's up to you.
We're a nimble group.
They switched the orders of our slides. So. What do you think? Funding the parent? Why don't you go back? I think you're the natural next.
All right. All right. Back on it. Thanks for your patience, everyone. So how do you find, if you are thinking, hey, I have this great idea, and I want to check, is there another trial that would potentially, help me do my aims, in a more effective way without necessarily recreating the wheel? How do I even find out about these? So here's some of my disclosures. Hold on a second. Let me fix that. Yeah. AV issues.
You want to present a view? Oh, it's...
Is there anybody that can help? Anybody technically savvy? Ruh-roh.
It's weird.
Do you want me to help as the parent of your child?
Yeah, I know, right?
Hey, Will.
What's up, Will?
Oh, maybe you want to close and then open.
Yeah.
Maybe close and open.
We'll let our AV.
It's just not progressing, or?
Yeah, it's not,
Yeah, it's not matching the screen.
not progressive.
Is it right here, like if you wanted to pull it back up?
Yep.
Somewhere to go.
You can see your mouse now, you can see.
Got it.
Or it's not just us.
Well, why she works on getting the things that, I'll talk a little bit about kind of a few tips regarding how do you even find a project to work with. And I think one of the basic things is for emergency medicine is really the community that's around you right now and within SAEM. And so learning through talks like this or through other groups within here, what other projects are being funded or what other applications are going in for funding that might align with your area of science. Now, and sometimes that could be at the stage where people are still applying for an award or that they just received an award. Now, if an award has been, if someone's about 3 or 4 years into their R01 award or of a clinical trial or whatnot, then the timing of your ancillary study may not stick like that. So even if you submit an ancillary study right now, chances are you wouldn't have that funding until potentially April of next year. And if that trial is almost done by that point, depending on whether you need to change the actual, change, parts about that trial, whether it be consent or additional data that you're collecting, it may not be possible. However, if you're analyzing biomarkers from that trial that are already collected, or analyzing we are, looking at analyzing waveform data that's already being collected, then maybe even tagging it on toward the end of the trial may actually work. So it very much depends on what that existing trial, what stage it's in, and what you're planning to do. So in our case, what I've been involved in the Siren network for a long time, along with Will and some of these guys. And so the Siren network does a lot, previously was the NET, and now is the Siren network, and does a lot of acute neurological emergency trials and cardiovascular trials. And within that network, there's a lot of subcommittees, subcommittees that meet on a monthly basis to discuss different aspects of, based on topic themes. So it might be on pre-hospital trial ideas, cardiovascular trial ideas, et cetera. And so what we did is, I've been part of the cardiovascular subcommittee for quite a while. And so within that, we would routinely discuss, what kind of ancillary studies can we consider for all the Siren network trials that we know are either going to the NIH for review or have recently been funded. And so as we did that.
I made it work.
Nice job.
This is
All right.
why, this is why he is who he is.
Yeah. Thank you, Will.
Thanks, Will.
So again, so what we did through the Siren. Now, obviously, there's other networks too, such as whether it's StrokeNet or PCARN, et cetera, SAEM Research Connections. One great thing for all of us is that there's more emergency physicians that are currently NIH-funded for awards, and there's been for I don't know forever, but for a long time. So there's a lot more opportunities out there to potentially partner on. I mean, you could go to NIH Reporter and you could look, if you don't have the connections to the existing networks or existing people within SAEM community, and certainly look within NIH Reporter for other ideas. And particularly, this might be useful because there's a good chance there might be some opportunities outside emergency medicine where you could ask a relevant question to your area of science that could be built onto maybe a cardiology trial or a, you name it, aging trial, et cetera. So I was talking earlier how, I was very involved with the cardiovascular working group within the Siren network, and so we were meeting monthly, and I was fortunate where, we were talking, and I'll give Brian O'Neill a fair amount of credit. He helps lead that working group. And so Brian O'Neill, we were talking about the opportunities for looking at autonomic dysfunction in TBI, and I have another collaborator at Wayne State that has an interest in that named Z, and so we were talking within that group, and then Bill Barson, who's kind of the godfather of the NET and Siren, was gracious enough to connect me and my collaborators in Detroit with Vijay Krishnamurthy, who's a guy that has done work on autonomic dysfunction in TBI and was very interested in the concept of putting together a larger project around that. And so we partnered with Vijay, and we were able to put in an R01 application to look at autonomic dysfunction within the Boost 3 cohort, which fortunately leverages a lot of the data that is there, although we have had to request sites to make sure that we're getting the data we need and make some small adaptations to really optimize the data collection. I'll give just one other example too. One example of someone close of a non kind of emergency medicine group is we have a group out of Wayne State that has a National Institute of Minority Health Disparities project grant. And one of my cardiology colleagues really had an interest in doing a trial around heart failure related to actually using air purification, so randomizing patients to get an air purifier that sits in their bedroom all day long, well, particularly when they sleep, versus usual care to see if it actually improves their repeat encounters for heart failure exacerbations. And so he was able to leverage that as somewhat of an ancillary trial onto an existing network or project grant, which project grants are often large grants that are kind of around a certain subject area, but may have different trials or different projects going on in an area. In this case, the area was around cardiometabolic health in Detroit and in Cleveland, and a bunch of projects around that. So lots of different opportunities to that. And I think, in terms of the process of collaboration, for us, it started with, developing an Ames page, taking it to the Boost 3 leadership with Will's help and others' help, and then seeing if they think it'll work within the trial context, and then refining that, and then going through the eventual full proposal to the NIH. So I mentioned briefly, like, the timeline matters a lot. The timeline is critically important as you consider whether your ancillary idea or your science would match well with an existing trial or existing project. Of course, feedback. We got a lot of feedback from the Boost 3 leadership team and continue to get feedback. We have monthly calls with them to continue to kind of refine the approach that we're taking. I think probably it's pretty obvious, but you will need letters of support, strong letters of support from the parent trial as you prepare an ancillary study. And then there are a lot of budget considerations in terms of how, for instance, within SAEM, we had to budget some money to the Data Coordinating Center and to the Coordinating Center at University of Michigan. The budget wasn't just for the people that are actually carrying out the project, but also for all the people that are working on the data and working with that. And then in this case, we also had to partner with Moberg, which is a company that actually collects the data into a device and then puts it on that cloud, and then they're going to give it to us. So I think, again, in general, there's more and more NIH-funded projects that are going on with emergency medicine and more opportunities to consider ancillary studies. The last thing I'd say, too, is that, as I'm preparing grants often, like, I might have like 4 aims I really want to do, but I know that unless I'm going to ask for above the NIH cap, that I can't afford to do all the 4 aims. So inevitably, I'm going to drop one aim. So a lot of investigators may have another idea percolating behind a study that's being funded and may be willing to, if it aligns with what you want to do, maybe a great opportunity to look at ancillary ideas. So with that, I'll turn it over to Jonathan.
You're number 2. Yep.
Hey, look at that. Thank you all for being here. So I was asked to talk about choosing the right mechanism and making good aims for an ancillary. I also have disclosures. The asterisk things are ancillaries, but not any deep conflicts. Can I ask, before I talk about the right mechanism, I only recognize like 60% of the faces in the room. Are there program officers from NIH in the room right now, or did they all sneak out after the last session? Okay. Then I will not call on you. So, I think in terms of the mechanism, probably everything that I say about an ancillary study is true of any NIH-funded project without a ton of unique considerations. So I think most folks in this room know this already. You have an idea, and you kind of codify the idea, and then you make like a back of the envelope sketch of what your budget is, and you see, like, is this a 2-year project for $200,000 a year, or is this a 5-year project for $3 million a year? And you start thinking about, like, what is the science that I want to do, and then start hunting for who's going to be interested. I will say for my ancillaries, that hunt was not super broad across institutes, but as you saw in earlier talks, there are examples where an ancillary might find multiple homes at NIH, and so finding an institute and a program officer who is interested in your work is obviously important. Again, this is not a comment about ancillaries per se. This is NIH funding in general. And I'll go through this a little bit more in a minute, but I think you'll find ancillaries that are responsive to a particular call for proposals. But lots of the ancillaries that you've seen presented here were submitted to some parent, very generic grant mechanism, like an R01 or an R21. So, NINDS is mostly where I've gone for funding. They have a website like this. Many of the other institutes have something that is similar. So for NINDS, you can type basically anything into that text box at the bottom there. I typed ancillary in a couple months ago before the slides were due, and you see some things. NINDS has a specific call for proposals through a UG3, UH3 mechanism, so like a biggish budget grant, where they say, we're looking for ancillaries that add science to existing StrokeNet studies. That's awesome, just like, again, whenever you're going to NIH, if you can find a call for proposals and your proposal fits in, often those are a little bit less competitive, more likely to be funded. They show that there's an institutional priority to try to get science developed in this space, and you're in that space, and it's a match made in heaven. That's often not the case. So you saw, I think, the Siren website already. We have some of Siren's leadership in the room who can correct me if I'm wrong. I think these are the major trials that are going on through Siren right now across the top. They're the parent trials, so they have pretty pictures. The blue studies under those are ancillaries. And the red studies at the bottom are more ancillaries that are still at sort of various stages of development. So, 5 trials, but 10 to 12 potential ancillaries. In terms of mechanisms, which is what I was asked to talk about, basically for Siren, except for sort of the funny COVID, we invented some mechanisms, everything else is an R01. And when I went through, almost all of these R01s are over cap. And that, I think, reflects something that you heard in the first talk, which is that ancillaries can be more efficient in terms of some of your recruitment, some of your data collection is taken care of already. But if you're going to do an ancillary through a large clinical trials network, there's often a lot of benefit in terms of the administrative support, but also a lot of cost in terms of the administrative infrastructure at the clinical and data coordinating centers, which often mean for these trials that $500,000 a year just doesn't quite cut it, because like half or more of that would be going to the network who's administering it. So again, I think nothing that's unique to ancillaries in terms of aims. You figure out your science, you figure out your budget, you see if there's a specific call for proposals, find an institute and a program officer, and then in a default scenario, which at least within Siren is pretty common, just submit it to a parent mechanism, and the program officers will guide that discussion. So a little bit more about aims, and I think this does get to be perhaps a bit more distinct for an ancillary. I think a common sort of aim that I hear floated during like early stage brainstorming is like, wow, there's this really cool trial that's going on. There's a network like Siren or StrokeNet or something else, and they're already screening, they're already enrolling, they're already collecting data, they're already following up on patients. And if I could just get this piece of additional data, I could really sort of understand something new or different about this disease. And what I would say is that's like, those are okay aims, and some of them will fund. But really the major argument you're making there over just, I want to do my own observational cohort study, is that it's going to be cheaper and more efficient, which NIH might like because it leverages sort of some of the cost savings of the network. But I don't know that it's super scientifically innovative consistently, as opposed to just writing your own observational cohort study and getting a lot of data and doing a lot of follow-up. So I think better is to take the tool that the trial is using, usually randomization, and then to use that instrument, plus all of the data, plus a little bit of more data, to start to do something that you can really only do within a setting of an RCT. So, you all know this because you're in this room, you randomize patients and you use that as a tool to try to sort of understand causal relationships as opposed to associations. And in the context of an ancillary, you can then use that trial intervention to start to understand, say, a mechanism of action. How does this biomarker differ between arms in a way that would explain how the intervention is working? The trial or the study that we're doing is trying to identify phenotypes of treatment response. So you're randomized to a treatment arm, and then we gather a lot of data about that subject, and we try to understand, is there an interaction between those clinical characteristics and the effect of the treatment on outcomes that would explain in some way a potential tool that could be used to target that treatment prospectively to the right patient? Can I try to understand the effect of the treatment on the longer term outcomes outside of the bounds of the study? Again, a causal question. So, to me, scientifically, those are better aims. Those tend to be the ancillaries that fund, although not exclusively. And it lets you say to study section and to NIH, really, I couldn't do this as an observational study. I need to be able to randomize patients to do the science that I want to do. And so funding this as an ancillary, even if there's network costs and this cost and that cost, and even if there are risks, like the trial ends early or otherwise, it's worth it because I really can't do this without that randomization as a tool. So, I think I'll wrap up there and we'll leave a good amount of time for discussion, which was our intent. I don't think that there's a single right mechanism. Like every grant, like every project, it's guided by the science and the budget and what the program officers say. You don't need to restrict yourself to mechanisms that are looking for ancillaries. Lots of generic parent R01s, R21s will take ancillaries. And the best aims that I've seen and the most likely, I think, to get funded, although this is anecdotal, are those that take advantage not just of the resources and the infrastructure of the trial and of the network that's doing the trial, but also the actual intervention, the instrument of that parent trial, so that you can start to try to tease out causal relationships in a way that you can't just with a large prospective observational study. And I made the slides go away.
So thank you for our speakers. I'd like to have engaged audience. Anyone has any questions?
Sure, I'm starting up. Hey guys, thanks for that presentation, super informative. You guys kind of answered some of my question around timing, but I got the sense, correct me if I'm wrong, the study could be completed and you can reach out to those PIs and talk about initiating. It could be not even started and you can reach, so it could occur at any time?
Yeah, I was gonna say, it definitely can. A lot depends on what you're doing. Like, for instance, say you're submitting an ancillary R21 to do like some kind of secondary data analysis. Like, I mean, I guess I haven't looked systemically, but my guess is most of the ancillary related R21s for secondary data are mostly looking retrospectively at existing data to run analyses that the primary team didn't do or didn't have the funding to do. And that exists too, even for like, I guess I don't always think of these as ancillaries, but there are lots of biobank specimens within NIH that you can apply, and sometimes there's RFA specific asking for this to do secondary analyses on existing data sets too.
Thank you.
What would you use the money for a secondary analysis if you have data available already?
Your time.
Thank you.
Time, but also, so biobanks in particular are not always cheap to work with. So, you gotta get the samples, you have to process the samples right. You're gonna do some new ELISA or multiplex something on banked blood specimens, and then you're gonna analyze the data. So, your time is important, even if it's just like in silico analysis of a large observational data set. There's gonna be an analyst's time and a project manager's time and a research coordinator's time and a regulatory person who's going to help you with the IRB and all of that. So I think, again, this is not specific to ancillaries because you could say the same thing about, like an observational study of CMS data or a VA health record data. The bad thing about these grants is that from when you put pen to paper to when you submit it is a year, and then it's a year before your sort of first funding decision, and then you resubmit it, and then it's another year, and so you're like looking 3 or 4 years out before the check is there if you're successful. But the good thing about it is that all the things that you otherwise have to do just through sweat equity, like take your lunch hour and write the IRB, and then do the this and then do the that, you can budget for in the grant, and very quickly those personnel costs add up.
Yeah, and just to clarify, I think what I've learned is that that's what we term a sub-study also oftentimes is secondary analysis, but the answer is collecting extra new data or new sort of type of analysis as well, a very sophisticated one. And then to answer your question, it can be at the same time. Oftentimes, for example, my experience with the process, and it's actually Nate Shapiro is the R01, and I was sort of part of that main group and subgroup, right? So, and only a few groups were able to do this sort of ancillary for Nate Shapiro, collecting more biomarkers and all that. But that was that at the same time where they submitted, got the grant, but immediately got the R1 at the same time. Yeah, so you can plan it that way if you sort of investigator within the network are already doing something in the parent, but then you can do other things off of it at the same time as well. And also others can also do it at the other times too to add on to it, such as the pedal network, right? The initial neuromuscular blockade one, it was actually also planned, but not exactly the same time. There was also Primrose looking at also long-term outcomes, cognitive outcomes as well. Yeah.
Just out of curiosity, when did you guys start the process for your ancillary studies for AutoBoost and Precise Cap?
Well, I mean, actually, it was probably at least.
Well, the picture you had showed my 2019 hair.
Yeah.
So it was at least back to that.
It was at least back then, yeah. So it was probably 2019, and we probably spent 6 months just kind of discussing the ideas around it. And then, once we formed a team, that probably, that took another 6 months to get the application together and to coordinate with the Boost 3 team. And then we were fortunate that we did a multi-PI application, and one of the PIs had continuous submission. And so we were able to submit kind of a little maybe earlier than we otherwise would have. But anyway, and we were fortunate too that I got funded on the first round. I mean, we were actually anticipating it would get funded later. But the whole time frame though, from initial ideas to get the team to submit to funding was at least 1.5 to 2 years. So it is a long period. We're fortunate that Boost 3 is a very long trial, and that made a little bit more allowance for this. But if it was going to be a 2-year trial, it might be a lot harder to pull it off.
That's an important consideration, is the length of the trial, because if it's going to be over I don't know, how long, when did you start?
Yeah, so we were also fortunate to fund on the first round. And I think that's not coincidental. I think you hear that a lot with ancillaries because they do understand that you're tied to another study if you're doing things prospectively. And so if they like it, I think they may be a little less inclined to nitpick you on some of the details, because that can set you back a year or two and may actually just sabotage you. So it was about 2 years before we funded. So I think we talked in the first year of IceCap, did some meeting, did some writing, submitted, and then again from submission to the check is another full year, even if you fund on the first cycle. The one other point I'll make about timing, which may be so obvious it goes without saying, but the parent trial should be successfully funded before you submit your ancillary. So submitting an ancillary whose success is tied to an uncertain fate at study section of another trial is probably not worth your time.
And that's the tension, right? That's why I think a lot of us, you notice it was network trials like Siren and Pedal Network, and that's part of the reason why, because it's a different way of getting these studies off the ground. But it's a tension trying to find that study that will get funded, then timing and getting it then once it's funded, submitting the application immediately to get the ancillary study funded.
Yeah, that feels like the trick here.
Yeah, that's a trick.
And may I ask one quick follow-up on that? When you did submit the grant itself, did you put specific importance around the timing in your, why it was important that this goes down now and not 2 years from now? You add those type of details?
Yeah.
Thank you.
Several times.
Both timelines. I mean, you make one figure,
Yeah.
a parent study timeline, your timeline, and where the recruitment will overlap.
Hey, thanks, guys. This is a great presentation. I have 2 questions in different veins. I guess, Jonathan, your point about leveraging randomization as sort of the premise, I always looked at that and thought that could be a confounding variable, but I guess it's only if you're really thinking about that as an observational study. And so what you're saying is to kind of flip that on its head and say, no, we need the randomization to do the study that I'm interested in because I'm studying the intervention itself, right?
Yeah, I think that's right. So I think, I mean, you know this, that randomization should balance things out that are present at the time of randomization. And so I think, what I'm saying is, again, exactly as you said, if the topic of interest is the study intervention, then the randomization is a strength because it takes away all of the other confounders that you would have to worry about, and then it lets you make a very sort of clean causal argument. Now, I think it's a little bit of grantsmanship and then sort of battling with journal editors if you can really sort of claim causality in a secondary sort of ancillary thing. But I think if you're careful about it, you can get away with it, and I think appropriately so, because even if it wasn't the a priori intent, the sort of framework that supports causal inference through randomization is still there and is still sound.
Right. But a less good study would be one that has really nothing to do with the intervention, that maybe is like basically an observational study. And again, what you're saying is you're just trying to leverage the trial network in general, right?
Yeah, and I would say, like, you know, in the instance of AutoBoost, it really is more leveraging the network and the high fidelity data collection that may never be recreated without, you know, many millions of dollars
Right.
from the NIH.
So, and then my small question, additional question is, have you guys seen, looked like you did some research on mechanisms of some of these studies. Have you ever seen a ancillary or sub-study funded as a supplement to the parent grant?
We have a few, our ancillary has a few supplements. The supplements usually from NIH are like $100,000 or $200,000, usually just for a year, and usually for a very specific targeted purpose. They don't go through peer review. They're essentially, the institute looks at them as an internal process and says, these things sound pretty cool. So they're a very fast turnaround. I think our supplements from submission to funding were like less than 4 weeks. But the scope of the budget is much smaller. So I think it would be difficult to do something, both because it's tied to a 1-year funding period usually, and it's a small budget. I think it would be hard to try to pull off an ancillary. I mean, the advantage of the supplements is they're really fast. You know, you like write 3 or 4 pages of your best ideas, proofread it once, send it in, and then you get something back very quickly thereafter, but they're small.
In my Orchid Bud study, the hydroxychloroquine was a supplement through the NIA, but I also think it was a function of COVID and the uniqueness of COVID as well. But yeah, it was 1 year, but I actually made it into a 2-year grant through a no-cost extension. And we made it work in terms of budget, but I got like 0%. The other thing is I'm technically not the PI on paper, even though I wrote the entire grant. It's Wes Ely who was the PI on the grant, but yeah, that's fine. It's one of those things where it's got to be the PI who's the submitter as well.
The parent, yeah.
Oh, the parent, yeah.
Thanks, I learned a lot. Where I see a lot of utility for this, actually I'm thinking for Joe and us at Becca Henry Ford, is if we have clinical trials going on, if we want to see if secondary interventions work, then we can go back into the data and do propensity matching and looking at something totally different. So for example, I do geriatric emergency care, right? So maybe the initial intervention we were looking at was comprehensive geriatric assessment, but maybe we looked in and we saw 50% of patients actually also got a PT assessment. So I want to do a propensity match study to see, does that intervention of actually even seeing a PD do anything before the fact? Is that kind of along the right lines there?
Yeah, I guess like in the real vein though of like ancillary, the question is, are you going to add some other component of data collection that justifies a certain level of funding? It gets back also to what mechanism of funding you're approaching.
Yeah.
But,
I mean, I think if you were to, if you need Medicare data, if you wanted to do like return visits those are always tougher. I mean, I think Joe's a unique case. He's not really collecting, he's fine tuning the data collection, but I think he's also, he's identifying autonomic dysfunction in an innovative way that couldn't be done otherwise. So I think it's that would be, I think, difficult to fund unless you gave
I think
him,
that's why I was confused. I was like, how do you fund that? Because that's what I was thinking of.
yeah, it would have to be
Okay.
an innovative, it would have to be a very innovative analytical process.
But I think, again, I think what John is thinking is that frame probably your question so they can use a randomization. That is actually what's the most powerful. And a lot of the R01s are using that as the, sort of a argument, right? Because you get rid of a lot of the confounders. That's the thing, right? Exactly, and that's the beauty of it, right? You have a parent in a randomized controlled trial. Ancillary, if it's a randomized control, it's actually a lot easier to actually justify a lot of the funding causal effects.
Yeah, and what I'll say, like, you can use the randomization and still explore another quantity of interest. So, the ancillary you've heard about that we're doing, we're really not that interested in temperature duration. It's not the main interest. What we're interested in is identifying phenotypes of treatment responders, right? So we're using dimensional reduction to identify sort of phenotypic signatures, and then we're just looking for an interaction with the treatment. So your example of PT, you can take the randomization, accept the randomization, call it a strength, and then look for an interaction of the real intervention or the real quantity of interest with that. Still get some of the benefits of the randomization, still be able to make a scientific argument that embedding it in a trial is important or useful to you analytically, but hone in on a different quantity of interest. So for you, it may be some other non-randomly allocated treatment. For us, it was signatures of treatment responsiveness. So we just said, IceCap is making a dose response curve with functional recovery on the y-axis and duration of cooling on the x-axis. And so we said, there's going to be phenotypes where the dose response curve is a flat line at 0, right? We all recognize those patients clinically. Nothing you do to those patients matter. There's going to be patients where the dose response curve is a really good line and nothing you do matters. And then maybe there's a subgroup where there's some more complex relationship that's of interest. So fundamentally, we're sort of asking a question about temperature duration and using the randomization, but really what we're asking is, can we recognize signatures of patients who are too sick or too well to benefit from an intervention? And using randomization as the tool to do that. It is sort of about the intervention, but it's really that interaction where we're trying to get at a different quantity of interest. So I think you could do that also, and then really turn it from a secondary analysis of existing data using a cool method to something that's a little bit more squarely in the ancillary wheelhouse.
Any other questions? One last question I have, the reason I actually proposed this, because kind of getting on an ancillary, is that from our SAEM research mission, how can we really engage our really young investigators, right, and also our trainees to really participate in the parent trial, although that's hard, right? Even the fellows sometimes done it before, but it's actually so hard, clinically training oriented. But a lot of same thing with ancillary study, how we can engage them in some of these studies.
I mean, that is tough. I mean, we're all in that boat in terms of trying to bring up new investigators. I do think, just to put a plug, this is just one venue, but I would put a plug for the Siren working groups are very comprehensive. Pre-hospital, recovery, cardiovascular, et cetera. And so groups like that, that are very open to any investigator at any level to chat with experts in the field, representatives from the NIH often, call into these working groups. And so it's great opportunities to start vetting these ideas and help people, think about where they can approach these. And I'm not as familiar with, what the PCAR network does and other networks do, but I envision that, hopefully there's other opportunities out there for these.
Yeah, and I think getting your junior fellows, mentees involved in these meetings, I'm part of the Pragmatic Critical Care Research Group that does a lot of the airway trials, and our mentees are part of the discussion, and they're always part of the process, and just getting them involved, and that's just part of their training as being part of this research group.
Yeah, a lot of my experience is also with Siren, so I'll echo some of what was already said, but I think not just these working groups, but the trial operations and organization and structure and everything else is very open. So Siren has sort of formal fellowships that allow some degree of engagement with a study or an ancillary. I think for trainees, the downside is that trials move so slowly and so much time is spent doing things that are just really not sexy and exciting. Super informative, I remember going to an IceCap trial call before our ancillary fund, and like the whole call was spent discussing what to do with someone who had come in, was eligible, they went to go consent and randomize, and in the interval from when they left the bedside to consent and randomize, the patient had died. And so, could the patient have been enrolled? He was dead already, but there was an intention to treat, and and this long, hour spent trying to figure out what do we do with this one troublesome patient, which on the one hand I found incredibly eye-opening, having never done a trial before, just about all the unforeseen things that can go wrong that you never would have anticipated, and then have to come up with a scientifically acceptable solution to. On the other side, if you have a year of research fellowship to engage with this, that's a lot of hours spent on stuff that are one-offs. But I do think at least dropping in sporadically is fine. I think almost every siren call, and there's a lot of siren calls on Zoom, if a trainee or a junior person contacts the folks who organize it and say, can I come to some of these? The answer would be yes. I know for the ones that I'm involved with, if anyone wants to come, you're welcome. I can't speak for the co-panelists, but I think in general, we're all very open to having folks come. We just can't promise it'll be exciting.
But it's also great, for junior investigators that are looking for potential career development awards, which may not be an ancillary study, but it still provides the same kind of networking to get the right content expertise, potential, guidance, et cetera, to develop career development awards too.
All right, well, thank you for the speakers.